Welcome back, guys, to another episode of SynergyTalks. I know it's been about 2 weeks since we spoke last time. Last time we met, we went over some great things that we saw at LMT.
We did.
And this week, we're going to change it up a little bit with the importance of planning pre-treatment. We're specifically going to talk, I think, about implants. A majority of the conversation is going to be when we're dealing with implants. But I think we should actually start by talking about every prosthesis. I think there's a big misconception in the industry that planning should be only really thought of pre-large cases, right? Allonx work, if you're doing a full mouth rehabilitation. But the real realization of everything is that even when we're dealing with a single or double or 2 units implants, we'll show some scenarios in this conversations of what we feel the do's and the don'ts and the troubles we go through in a restorative aspect. And if we really work together to plan the cases appropriately, it'll help us get a better aesthetic restorative for the patient. It's not just the aspect of the better restorative, but it's the aspect of efficiencies, right? Our whole plan here at Synergy 3D is always the fact that we feel we're one of the fastest manufacturers in the industry by utilizing digital technology. Obviously, the evident with consistency and quality that come with that as well, too. But to be able to give that consistency, quality, and efficiency, it's always important to say, okay, I want to do X to this patient, and this is how we're going to achieve it. This is what they like. This is what they don't like. This is what they're starting with. This is where they want to end up. And having a true expectation of what we could achieve.
That efficiency is only as good as the planning that's involved with restoring a case or with the data that you receive. It's only as good as everyone's involvement in the case, right?
Absolutely. Yeah. I mean, a great example is we did a restorative case for one of our clients. It was anterior 8, I think we did, for this particular patient. It's a client we have in Florida. She did everything by the book, everything phenomenal. Gave us a pre-op scan, upper and lower. Gave us the bite pre-prep. We were able to treatment plan a diagnostic associated with the temporary. And by doing that, and also photos. So we were able to overlay the imaging with the photos so we could give a good understanding, not just the practitioner, but to the patient of what they potentially could look like.
Right.
And by doing that, we took a lot of the variables and guesswork out, right? A lot of times, or how many times do we see a doctor will prep anterior 6 or anterior 8 and not give us any pre-op scans, right?
Exactly.
So we lose VDO, depending on how many teeth they have in the mouth. We lose shape and orientation. We have no photos. Although we still achieve success with that, things go a whole lot more smoother on the back end when you have everything you need. Yeah. So it was simple. Doc got her diagnostic wax up, digital print out. Doc got a channeled out temporary. Right after prep, was able to reline it. It was within 99% of exactly what the patient was expecting. And saw the patient the other day. And the following morning, we had the digital intraoral scan of the preps. She went the next step of even scanning the temporaries in the mouth, so we can see if there was any variables of what we had initially to what the actual prosthesis looked like. And now we're going to final. And
at this point, you mentioned so many steps that we already have so much data that we've collected along the way that you would have to be very incompetent not to be able to put all that together and execute a flawless case.
Absolutely. Yeah. And when you're thinking about so many teeth and so much we're taking away, it gives us so much more success, right? So it is very important that we have that initial thought process when we're seeing the patient, right? To say, what do we want to achieve? Obviously, we're doing, 1 molar posterior. You're going to prep that. We're going to produce it. It is what it is. You're doing a single unit implant placement, I still am an advocate of, measure twice, cut once. Mm-hmm. So having that data makes it more seamless and more predictable.
And a surgical guide is that first measurement.
Right. That's surgical. Exactly. So surgical guide, right? So Milos, let's talk a little bit about, we have doctors that are listening right now and they're saying, you know what? I kind of like what they're saying. I don't use surgical guides now, or I might not do implants now. For your team, what is the protocol for a patient comes in today, whether they want 1 implant or they want 6 implants for an allonx? Why don't we go through exactly as a laboratory whether it's us or any other laboratory, typically what's the best data for them to gather?
Sure. So actually executing surgical guides is one of the easiest things we can do in a lab, but it provides such a good foundation for having a perfectly executed case, both aesthetically and functionally. So let's say we're restoring a case where we're just replacing one implant. The tooth has been out for a while. The doctor wants to place that implant. All they have to do is give us an intraoral scan of maxillary and mandibular arch in occlusion. That's one scan. And the second scan is going to be CBCT scan. CBCT scan is basically a 3D X-ray, right? It's a series of 2D X-ray images combined into one. Nearly almost every office now has a CBCT scanner, or sometimes they outsource it to the nearest office or facility that can scan it for them. Then we'll take these scans, we merge them together we utilize 3Shape Implant Studio, but we also play with RealGuide, we use Co-Diagnostics, we use various surgical planning softwares that are basically the leaders in the industry today. We will overlay those and we will create a surgical proposal to the doctor where we will place the implant that we think it's most appropriate for that site. The things that we look for are bone density, if the patient has enough bone density, which will show in a heat map in a surgical proposal. Then we look for things such as if we're doing a maxillary, we're doing where the sinuses are. And if, let's say we've chosen the shortest implant, but we still don't have enough clearance because the sinus is right there, we might suggest a sinus lift. All that will be outlaid in a surgical proposal. And on the mandibular arch, the most important, the most critical part of all implant planning is bypassing the mandibular nerve, which means you have to have a nice crisp CBCT scan so that we can mark that mandibular nerve going all the way from the ramus of the mandible, going all the way along the line of mandible through the foramen. That's the most critical part, and we mark it. It also gets marked in a surgical proposal as well. And then we make sure that we stay within 2 to 3 millimeters away from it at worst. You don't want to really get any closer because it's a very critical nerve. If it gets damaged, the patient can get paralyzed. So what the surgeon will get, long story short, they'll get a proposal, they'll review it. If they like what they see, it's pretty straightforward. They'll sign it, and we'll go ahead and produce a surgical guide with either a fully guided sleeve or a pilot sleeve. Sometimes some doctors prefer the pilot, so they can at least almost like mark where they need to drill, and then they freehand the rest of it. But some prefer the fully guided system because it's a no-brainer.
We're fully guided, and we say surgeons, but a lot of GPs take advantage of this as well too. More and more GPs every day are placing implants in their practice for convenience for patients, increase revenue, things like that. But fully guided, it
that's
basically
the way to go.
I mean, it literally stops the handpiece, so exactly you're at the proper depth. There's no variable whatsoever. Maybe a more experienced GP oral surgeon wants to freehand it because it gives you a little bit of variable, to slightly adjust that orientation. But if you want to truly have a 99% success rate of getting the exact aesthetics of what we pre-planned with that surgical guide, obviously fully guided is going to give you a better result. And
if they are a type of clinician that doesn't want to use the guide, they just want to kind of get an assessment or a planning, we provide that service too. We just do sort of like an implant consultation. The thing about it is sometimes people underestimate, it's a single tooth, it's an easy case. You can find once you start looking at the X-ray, the CBCT, and the surface scans, you can find a lot of problematic things. You can have issues with how much interproximal space you need, right? Whether or not that sleeve is even going to be able to fit in between. Then you have angulation issues. If the bone is in a very particular position and the buccal plate is very thin, you have to flare out your implant. Now you have to think restoratively. How am I going to do this restoratively? Do I have enough tools in my toolkit to bring that screw channel back in the final restorative? So there's a lot of things that we prefer to address in the beginning of the case that usually, whether it's time constraint or skill or experience, whatever the case is, that do end up getting addressed on the back end. And then we have to do all sort of like mental gymnastics to make it work.
Well, it also goes to the fact of even basically when you think of how many times have we done a single unit restorative where there's not enough VDO, there's just not enough space. Sometimes you can do an UCLA
Yeah.
abutment,
which is a cast too. Yeah.
Castable. That's why I'm not as familiar with that because we're much more digital. But you would have to cast it, and it's more labor intensive. It's more technique sensitive. There's more cost associated with it. So when you really look at it, all these things kind of get evaluated by doing that surgical guide.
Yeah.
Placement can be phenomenal. Angulation can be in the proper spot. Everything could be perfect. There's enough room width-wise to be able to restore it. But height-wise, with the VDO, the mouth is fully collapsed. And that's when now we can have conversations pre-surgery or during the healing process of saying, hey, we have to really start to work and open up that VDO. We have to prep the patient that there might have to be more restorative work done than just that single unit. So these are things where that little extra time in the beginning can save a ton of time moving forward at the final, right?
Another option that they have is if they don't like the surgical proposal and they want to tinker with it or tweak it, you just schedule 10-15 minute conversation with one of our techs, and we let the doctor actually control or tell us what to move as he's tuned in into what we're doing, and then we lock in the design and go to production. But general rule of thumb, if you're going to look at little tweaks that you can suggest, little tips and tricks, is always look for the vertical clearance, like you've said. Always look for the angulation, and you have to think restoratively in terms of materials. How am I restoring this case? Is this going to be a metal case, a zirconia case? Is it going to be a bar case, denture case? If it's a denture case, for instance, how many times we get cases that the teeth have no height of contour.
Yep.
So maybe, prepping some of those two teeth and then making a new crown over them with a good height of contour would actually allow for a nice RPD to fall into place.
Absolutely.
A lot of that planning needs to take effect. Here we're going to show some examples. I'm going to hand you one of these papers, and then we're going to comment a little bit about it. I'm going to have the same picture on the screen so you guys can see what we're saying. All right. What do you think about this?
Yeah. So on this situation, it's a perfect example where on the upper, they had a single placement, right? But angulation is way off, right? Obviously with anguli screw channels, we can correct 25%, but again, this is something that potentially could have been avoided with the proper planning initially, and it really does it. Now, when you look at the lower, it's a whole nother story, right? The initial placement, looked okay. You're looking at the abutments and saying implants and saying, hey, I think that'll work.
Close,
yeah, just a little close. But we're not thinking about now putting the restorative on top of it, as you could see, because we have that abutment design in the photo that you could see. They're literally touching each other, so there's no room for restorative. At this point now, the practitioner has had the uncomfortable conversation with the patient and say, hey, I know you paid for 2 implants on the lower, but unfortunately we're gonna have to put one to sleep, which is not ideal.
Now you're also cantilevering a case, which
is absolutely not ideal, right?
Yes.
So again, as you guys can see in this case, something that looks pretty self-explanatory, pretty simple. Easy. In the lower, it wasn't really in the nerve area, I think, right? Because it was in the interior. So the practitioner, the surgeon that did this case wasn't worried about that, saying, hey, this is a cookie cutter case. And then, the upper, one tooth, hey, I can make it work. Gets in there and doesn't realize that his insertion direction for the final prosthesis might be an issue, right?
When you deal with very tight spaces, especially in the lower interior section, I know that there's different levels that surgeons have or GPs have when it comes to implant placement. But when you deal with very tight mesial-distal width and you're trying to fit 2 functionally, aesthetically looking teeth, this is what the surgical guide would have showed you to the last fraction of a millimeter, where everything can go and push it to its limits and make sure that everything fits within that space. And
it, what it is that bringing these topics up in this podcast is not necessarily saying, hey, look at this bad work or this work. It's hopefully bringing awareness of avoidance, right? The uncomfortable conversation that the lab, whether it's us or any other lab, has to have with the practitioner. And then unfortunately, the practitioner has to have with the patient, So it's hopefully saying, hey, you know what? I've had that happen to me before. I've never had that happen to me before, and I don't ever want it to happen to me. So you know what? In this scenario, I might actually consider spending that little extra time to get a surgical guide.
And what do you think about the relationship between the restorative dentist and a surgeon. Let's say it's a surgeon that's placing it and offloading it. How do you see that dynamic playing out now, and what are the challenges for it to get better?
Yeah, I don't. So from what we hear, right? Because we're on the manufacturing side. It's always we get a call from a GP and say, I don't know. I think the surgeon was having a bad day today, or the GP, could be off. So the surgeon's main focus is getting those implants placed in a healthy manner where they won't fail, right? The GP has the headache of saying, "Now I need to restore this," and without a proper dialogue or conversation or pre-preparation, I could see things like what you just saw on the screen happen quite frequently. I don't know in this particular case if it was placed by a GP or a surgeon, or where it was placed, but the aspect is this is an actual real case that this happened to, and we have plenty of scenarios. So it's tough. I think that there's a little bit of a challenge there. I think the surgeon has more of a mindset of, like I said, placing that healthy implant, and then the GP says, I got to go ahead and restore.
Right.
And that's where the challenge is.
All right. For the next contender, we have a single implant placed for a 2-unit restorative with the screw channel going right in between on the interproximals. Oh,
wow. Yeah. So you're going to see this on the screen as well, too. In this particular photo, they actually use the desk scan body. We're going to talk about scan bodies in a little bit. Yeah, absolutely. But yeah, I mean, again, you got to think about, even if the designer in this aspect could get creative and try to put a screw channel in the middle of the 2 teeth, now you have to worry about the connections, right?
Yeah.
And the stability.
Mind you, you're not cantilevering one tooth, you're cantilevering both teeth.
Right. So you get that helicopter effect,
yes.
Right? So again, I'm assuming that in this scenario, they got in there, they were worried about the bone density, and they're like, this is the only spot I have. But having that cone beam, that pre-planning would give that surgeon or GP the opportunity to really be more proactive to get better results.
Can you tell also that this was an immediate placement right after the 2 extractions?
Oh, absolutely. You see the sockets. Yeah,
right.
Yeah.
So what usually happens is, if you do an immediate extraction, if there's not enough bone there, general rule of thumb is to go and pack it with some bone grafting.
Right.
And then wait for a little bit to heal. Sometimes, GPs are challenged with the speed, but long-term biomechanically, the restoration becomes problematic, just to save a little bit of that time. So I think it's very beneficial to assess a case like this and say, okay, if I'm extracting 2 teeth and I don't have enough bone density there, let me do a little bone grafting. In a few months or so, we can go and place those implants where they belong.
And I'm curious to see how this panned out, because on this specific case, I don't even know what to tell them.
We've had 1 decementation already on this case.
So this one, okay.
Yes. Yeah. So, because this is happening all the time,
right.
It's a seesaw,
right?
And as the patient is chewing, and so that's basically all we could do.
Right.
So what we did was we did make a custom abutment to extend the emergence profile and increase cementation surface.
Okay.
But unfortunately, the span is just too wide for it to biomechanically make sense.
Yeah.
And we always talk about that too when we restore hybrid cases, implant restorative cases. When it comes to cantilevers are the biggest culprit of them failing.
100%.
And even if you do your very last, most posterior implants tilted lingually to increase AP spread, you are still seeing now years after, especially the old wraparound hybrids, metal on acrylic, failing over
100%.
time. Yeah,
100%.
Oh, this one's great. All right, for the next contender, we got this one.
1, 2, 3, 4, 5, 6, 7, 8.
8.
So 8 implants placed, as you're going to see, right? Not spread out at all in the anterior. You have the 2 over here making love to each other. Yeah, again, I know there's the excitement of some GPs or surgeons getting in there and saying, all right, let's load them up, but again, it's the restorative. On this aspect, we could, design it to make it work. But in my opinion, there's also that mindset of there's such thing as too much, or too many. Yeah. Especially, if they spread this out through the whole arch and it wasn't all in the anterior, you could do a nice aesthetic restorative case on it. But everything being just jammed up in the anterior where they had bone, it was easily, you could take 3 to 4 implants out of there and still had great success.
I can tell you, when it comes to fit, less is more with hybrids. The reason is there's always micro movements in how, let's say, the tie base fits inside zirconia,
right,
or how each abutment sits, or how it gets milled, right, from your original design. The more units you have in a bridge with those slight movements, now you're creating a much greater potential for error of things not fitting. So now you have to account for 4 units slightly being off, which they will kind of compensate for each other. But if you have 8 units and every single one is a little bit off, now your whole restorative is not going to fit.
Absolutely.
So less is definitely more when it comes to these cases.
It's also the aspect, like hypothetically speaking, let's say this wasn't an allonx and it was going to be a cemented or a screw-retained, a cemented restorative, right? There's also the aspect of them being so tightly placed together. Your pontic areas or your connectors are limited. So it's the same thing as if tomorrow I go and take a 2x4 and I drill through that 2x4 every 1.5 inches. As I drill through that 2x4, I'm weakening the structure. So a little bit of a spread is not actually a bad thing, right? Because we could thicken up the interproximals of the prosthesis. We could actually achieve more aesthetics because we're thickening it out through the span versus all in one very small area that's going to make it look blotchy. And you'll actually get a stronger prosthesis from it. So again, I don't disagree on the upper of, if you have the opportunity and healthy bone, doing 8 implants, but 8 implants spread it out through the full arch, not all in the anterior.
Second molar, second bi, canines, laterals, and
et cetera. Like so this aspect was, it's just they're on top of each other way too much. Yeah. And in the long term, we foresee it to be a problem.
If you actually do second molar, second bi, canines and centrals, that would actually create an even spread.
Right. And that's really what you're trying to achieve.
Yeah.
The aspect is, and don't get me wrong, if someone's doing a full mouth rehab and they're doing a cement or single unit restoratives because they want nicer interproximals, they don't want to do a bridge. You could place 10 implants per tooth, but the aspect is it has to be spread out that way to get the best aesthetics and, being able to achieve what you're trying to achieve.
This next,
before we go to that, the preps, let's talk a little bit about scan bodies and how scan bodies, scan flags, everybody calls them differently, in the industry has evolved from the way it was, maybe even 5 years ago or 3 years ago to the way it is today. Like, for instance, when we first started Synergy, or any lab, you call up your lab and say, hey, listen, I want to scan for this abutment. Can you send me a scan body, or what scan body are you using?
Yeah.
Talk to them a little bit how that changed and how cool the industry is.
Initially, when it started, every company had their own scan bodies, and they were not compatible with any other competitor. So if you wanted to send a case to Oregon, you'd have to use Oregon scan bodies. If you want to send case to Lab A down the road, Lab A prefers true abutment scan bodies. That's what they restore, so you have to use those. And if you happen to scan a body with a different one, or OEM, and they simply couldn't restore it. And so what happened over time, you had all these multiple implant companies go out into the field, talk to all the GPs, and they just started either selling them or handing out free scan bodies all over the place. So that within just a few years, you have dental offices that have dozen or more different series or sets of scan bodies from all these different manufacturers. So the GP looks at it, the doctor looks at it, he puts it in a case. Oh, it's a Nobel Active RP. Let me take what I have, Oregon scatter, puts it in. Now we can't restore it. So what companies started to do recently, companies like Preet, companies like Des, and others, they started to realize, well, wait a minute, why don't we just expand our digital library that allows us to identify all these different scan bodies that makes it compatible to restore it on our system. And so they started expanding their library. So then now you can mix and match.
Yep.
You can take an Oregon scan body next to a true abutment scan body, next to a Preet scan body, next to a Des scan body for multiple implants in the same case, and we can still restore it in one shot without distorting the process.
Yeah, the nice thing about here at Synergy and most digital dental centers are starting to get more in tune to this and adapting their portfolio to be able to do it. But at least can say we could do it. There's probably 98% of the scan bodies, whether it's OEM or
you still get a few stranglers out there.
Yeah, but I would say 98% of them, whatever you scan with, as long as you tell us the company it came from, we could design it. Where, not even a year ago, we'd have to say, oh, you scanned with Glidewells, or you scanned with Preets, or we use DES, so you're gonna have to rescan with DES. So it's really nice that has evolved, and we're able to figure out the geometry where now it doesn't matter. Go ahead and scan, get us the data, and we can produce it.
So 3Shape a few years ago, which is our CAD design software that we use to design most of our restorative, had a solution for this, and they developed the universal scan body. So if it was internal hex 3.5, right, which is by Horizon, Legacy, or Zimmer, they had a scan body, and on the scan body there was a barcode that the scanner could read, and you can have this universal library that always exists. But unfortunately, they didn't come to fruition because there's no money in democratizing things.
Right.
So everybody wanted to make their own proprietary systems, which is what we are today. And even today, this process still continues as new manufacturers come to the market, as new implant types come to the market. Now you have to expand your library to support all those manufacturers. So it's actually gotten more complex, but that's the only solution direction we can go.
And with scan bodies, the most important thing we could stress is it's very important when you're scanning the scan body that you're capturing the data. So what happens is when we get that scan, for instance, with the DES scan flag we showed you, or whether it's Preet or whoever it is, there's certain touch points on that scan body that we align with our system that helps.
I'll show on the bottom of the screen.
Which he's going to show you, which is going to give us orientation of the implant you have placed. So basically, that's just a beacon that'll give us direction and depth so we could duplicate that in our digital software. So if you're missing data and we don't align it appropriately because that data is missing, that's where you'll have fitment issues. So it's very, very important. And some stuff made, we've gotten feedback that if it's made out of titanium for some implant systems, it's too shiny and you can't capture it. Or if it's made out of a pecton and it was autoclaved too many times, it's deteriorated, you can't capture it. I tell people use Quick Check or some type of powder spray to dull it up if you have to. Not if you had a sandblaster in that practice, which a lot of you guys don't, you could sandblast it, but not aggressively because you'll change orientation.
Newer scanners are usually better at capturing all of that.
Absolutely. But it's very, very important that, in that specific part, you don't let AI replace the missing data, because when we're missing that piece, it could give us a falsified read. And then you have other systems like encode, right? And the nice thing about encode is you're scanning a healing cap. Encode's been around forever, so we know a lot of you guys know this already, but there might be some that don't. Obviously, that healing cap has markings in it in a certain diameter dimension that by utilizing the markings on top and by utilizing the diameter of the healing cap, we're able to use that as the scan flag / scan body. Don't ever adjust that healing cap to seat and then send us that, because we will not have accurate readings and we will not be able to restore that.
And make sure that the tissue stays away, especially from the top of it. The more you can expose that healing abutment, the more accurate restoration.
Absolutely. So this is pretty self-explanatory. Healing abutments, scan flags, when I say healing abutments, I mean 3i, have been out in the industry for a very long time. But as new GPs or new surgeons are just getting preview to this platform, we want to make it known that look for these things as you're scanning. Obviously, you still could take a conventional impression, whether it's open tray or closed tray, and send us that. But because we're primarily digital, we talk mainly about the digital restorative. In my opinion, I don't understand why anybody would want to restore an implant case analog. Don't get me wrong. When you're looking at an allonx and you have a long spread of only 4 implants, there's sometimes not another choice. What we've been having with our clients is scan it. We'll do a verification jig. If everything verifies appropriately, then you don't have to impress. But with that verification jig, we send a custom tray so you can section it and pick it up if it's off for whatever reason.
That's a super accurate way of doing it. You're getting that verification jig. And if you had to section it because it didn't fit, like Enrico was saying, what you do is you section the jig, screw all the temporary cylinders down. Once they're nice and firm, you reconnect those pieces with Duralay or what's the other, like a flowable material, and Primotech. That's what I was looking for. And then what you do is you do an open tray impression coping. When you take a tray that we can design with pre-drilled holes and you impress that jig. So this way we get a verification jig and a final impression at the same time. Right. Super accurate way of doing it if you can't do it digital.
Right. And then, or if you can't, you scan it digitally and then we have a discrepancy because of the spread. So when I say the spread, basically what happens is that with standardized scan bodies, and Shining 3D has a solution to that. I think was it Implant Direct or BioHorizon has a
with those new scan bodies.
Yeah, has new scan bodies out that correct this problem. But with a standardized scan body, the span sometimes confuses the scanner because all the scan bodies are the same and the scanner loses orientation. But if you're able to capture it with most scanners out in the industry today, it's pretty accurate. So if you could scan it, send it, and if it's off, we'll print it. We'll make you a verification jig. If it seats beautifully, we're on to the next step. If it doesn't, then you do a pickup impression, and now we really have a solid, accurate impression that you move forward with. But obviously, our goal is always to move away from the conventional impression 110%.
And I just want to address restoratively one more thing when it comes to implant restorative is multi-unit abutment utilization. 100%. So any implant that's, I would say personally what I've seen, anything that's deeper than 3 or 4 millimeters, I would say probably 3 millimeters, that's subgingival, I would just put a multi-unit abutment on it. If we're talking about a full arch case that we're restoring. Multi-units serve several purposes. They bring the restorative part to the tissue level, and also because of their conical shape, they allow for very seamless and passive seat of the restorative, which biomechanically makes a lot more sense.
And at the same time, with a multi-unit, you could also then adjust up to 30 degrees. So you could also change your angulation just with a multi-unit. I always tell practitioners, definitely look at that. A call that we do get frequently is like, oh, I can't get this crown to seat, or the crown came loose. If you have a super subgingival implant, specifically if you're doing a screw retained and not a customized abutment with a crown or a screw retained crown over customized abutment, and it's just a standardized screw retained, you got to think about the thickness and the depth of trying to push that tissue out of the way. We just had a call the other day with a practitioner. He's like, listen, your crowns usually drop right in. I never have to adjust them. He's like, it's almost, it's like magical how accurate your implant work is. But this one case, I delivered it the other day, came loose, and I said, Doc, send me a picture, and he sends me a picture, and it was really subgingival, and I'm like, you got to release some of that tissue, and in that scenario, he knew it was subgingival, so he even requested a customized abutment with a cemented crown access hole, so a screw retained crown on a customized abutment. And I said, you got to relieve it. And when he relieved it, he texted me back. He's like, you're exactly right. Mm-hmm. Thank you so much. Sat beautifully. I have full confidence that it won't come loose again. So it's really, really important to evaluate those things so you can get the best aesthetics for sure.
Yeah. If you're going to scan tissue, anytime you remove healing abutment, as I'm sure many of you know, that tissue starts to shrink very, very quickly. So you really don't have a lot of a play time to go and scan. So you got to, plan your steps accordingly. Let's just go over. I want to go over this real quick.
Yeah, I forgot about this.
And then I want to address some of the stuff when it comes to preparation.
Absolutely. Yeah. So what you're going to see on the screen now was definitely either a GP or oral surgeon at his last surgery or her last surgery of the day, or very tired from partying the night before. But as you can see, these were placed right in the palate. We were able to restore this case, shockingly. But again, if I can't stress enough the importance of pre-planning so you don't get stuck in this predicament, this says it all. So I don't even know what else to say about it. When we went to go restore it, and I don't recall this was quite a while ago.
This was an overdenture case we ended up doing.
Okay. Okay, that's how we ended up doing it?
That's how we ended up doing it. We couldn't do it traditionally, so we did the strongest retention housing. Right. And it was an overdenture case.
Wow. Yeah, we had to convert it. So this patient started, surgery with the mindset of having allonx, I'm assuming, and it was just too far back, in the palate placement. So
too far back and closely together in a straight line, which creates so many mechanical problems. The cantilever alone on this case, we're talking probably close to 20-25 millimeters of how much we needed to push that restorative, which is why we decided to opt for overdenture, because we could have at least a full palate that will serve as a retentive surface for
that. Yeah. So guys, I mean, if this isn't an indicator of let's plan it. Let's plan it out together. That couple extra bucks, gives us sanity at the end. It's why not?
The next one I just wanted to quickly address, especially when it comes to scanning. I don't think there's enough awareness out there. What sort of preparations tooth preparations are appropriate for certain materials or certain types of restorative. So back in the PFM days, porcelain fused to metal days, you could go ahead and make a nice knife edge or a sharp occlusal prep. And since you were waxing it, it was a 1-to-1 fit. You didn't have to worry about any sort of compensation, such as drilling compensation. Now we mill our restorative, our lithium disilicate, which is emax, and our zirconia are milled. Every time you mill something, there's a limitation of that burr. The smallest burr that we can get is probably like 0.6 millimeters in general. You can go lower, but usually those tend to be very finicky to work with.
Yeah.
So what we indicate in our design software is, and I'll show you how actually blockout works on the bottom of the screen. We, if the surface is sharp, what the software is going to do, it especially comes to a point, it's going to create almost like a bubble around it to compensate for that features, because the burr itself has a certain diameter, and it's going to try to mill that out. What happens, it creates extra cement gap, and in instances when you have limited occlusal clearance, now you reduce the thickness of your restorative to compensate for all those features. So generally, what you want to do is you want to do shoulder prep or very deep chamfer with very smooth or routed occlusal surfaces. In those instances, you're going to get a much more intimate fit that's also going to give you very good indexing from rotation. And here you can kind of talk a little bit also how these grooves, really, by the time we mill them out, they really don't show.
Yeah. So, you know, in the past when you were doing a waxable, like Milos was saying, we wax up for the metal and we cast it, you know, that just, we didn't have any limitations because we weren't milling it. But at the same time, you know, so a prep like this, or what you're seeing on the screen, would somewhat be okay. In my opinion, I hope the doctor prepped this way. Maybe he messed up the preps cutting off pre-existing crowns. But in a zirconia or an emax platform that's milling, the mill's never going to achieve those grooves. So you have all that extra gap that could cause for long-term decementation, could cause problems with fracturing and breaking. So you want to, the truth is that when you're doing it, a nice shoulder prep is the ideal prep, right? And sometimes you can achieve it, sometimes you can't. But for long-term aesthetics, you know, what is your opinion? So hypothetically saying, if this doctor prepped this way, didn't prep this way, he cut off pre-existing crowns and he unfortunately nicked the preps, what would you recommend in that situation? To
go back and just smooth over that surface.
Let me ask you another question.
Or those, you mean those vertical grooves?
Yes.
I would rather fill those in with buildup.
Right. So that's what I was going to think.
Yeah.
You know, utilizing, you know, like a composite or what you use for your fillings.
Yeah, flowable.
Yeah, flowable. Fill those in, light cure them, get them nice and smooth, then reshape it. And then now you're giving a good solid structure for your crown to sit on. And you're not going to do the whole tooth. You're only going to fill your grooves in. So you're going to leave your natural dentition where you can. But now you're getting a solid structure. If that was caused by cutting off a pre-existing. Another thing we get a call about a lot too is that a patient has a pre-existing implant and abutment, and the doctor wants to just do the crown restorative because the patient got the implant placed 20 years ago, 30 years ago. Porcelain sheared off the PFM, and the doctor doesn't want to dive into Pandora's box by removing the implant itself. I tell docs it's not hard. It's very easy. Section that crown, take it off like it's a crown on a prep. The most important thing, if the access hole for that implant, for whatever reason, is not 100% sealed, utilize composite or wax or something to seal the hole, scan it as a prep, send it to us, and it's as easy as us designing a crown and redelivering it back. It's extremely simple. But the importance of covering that hole makes it a lot easier for your team for designing versus capturing that hole. Correct?
Yeah, correct.
So these are a couple little tricks of the trade of what we kind of came across as we've been doing this for many, many years. I have one more. Yes.
I'm sorry to cut you off.
Go for it. So I like the excitement. Bring it out, Milos. Let's go.
No, because it happened 3 times this week already. And with our customer support reps, I had to come to the phone a few times just to clarify. So there's most of our scanners are scanning color. Right. And so you finish your scan, you look at it. Oh, the white is the tooth, blue is the cord, and the pink is the tissue. Everything looks good. Let me send it out. What I can strongly suggest is turn off the color on your scanner before you send it out, and it's going to show you like black and white grayscale mode, right? In that grayscale mode, it's like a clay mode. It will show you the actual texture of what you've scanned. In that view, you can see if you have any discrepancies, missing data, any junk data or artifacts, especially along the margin. It will very clearly show you if you have a clean scan or you don't.
Absolutely.
So many clinicians today didn't even know that they could do that. And we had to send some cases back because there was a lot of discrepancies. There was a lot of junk data along the margin. But if you turn on the color, everything looks kosher, everything's good. But as soon as you turn it off, you see all these jaggedy lines and all this junk data that the scanner couldn't really pick up.
100%.
So if you want to make sure you're always double check color mode, grayscale mode, and it's a toggle switch that you have within the scanning software while the patient's still there.
Guys, you know, in the world of digital technology today, there should rarely be an issue, specifically when you're doing single unit restorative, of an open margin, bad contacts. There's so many tools within our software to measure, cross section it. You can measure how thick it is on the margin, how close to the margin, how close the clearance is, bite wears. So if you use these tricks to evaluate it before you send it, you're going to save yourself chair time. You know, I know the hustle and bustle. I used to manage dental practices in the past, pre-digital technology, and that your fast-paced environment. You're thinking about helping your next patient. You went over maybe with this patient, but those 2 extra seconds, whether you train your dental assistant to do it or you do it yourself, just evaluate that scan before you send it and use these couple tricks. You're going to have so much more success. I mean, when we get calls that, I had an open margin, or my contacts, I had to adjust them. It's because of the technology we have today. 99.9% of the time, it's because of the data that came in from the scanner. And I'm not saying it because there's no human error, just because the machine's doing so much of it. The design software's giving you so much data now that in the past, when we got an impression, there was tons of variables, right? And we talked about this in another episode, so I'm not going to beat a dead horse. But between expansion, porosity,
weather, temperature,
the technician not bringing his glasses that day and actually seeing the margin line, with scanners, with the shading and everything they do, I mean, it's pretty evident. You can see the margins very clearly. If you pack cord, if they're not subgingival,
we have them zoom. So every single case that we design, we have it zoomed in on a 30-inch screen,
right,
in 4K. So the entire prep of just a single tooth, so we can see every little discrepancy that's there. And like you said, the machine, the software can very accurately predict and very uniformly, predict the occlusal contacts and interproximal contacts. These are the settings that we apply in our software.
Right.
So when we hear that there was a big discrepancy, that's usually an indicator of something going awry with the scanner.
Yeah. And don't get me wrong, there's variables, and that's why we love the feedback. That maybe, there's a calibration issue with the milling machine, or, it might be the fact that, one of our settings got knocked out on one of our design stations. But 99% of the time, if we really dig into it, it's because we didn't capture, whether it wasn't, no cord was packed and that prep is subgingival and the scanner only has so much of a depth perception.
Blood, saliva.
And again, digital scanning is the same thing as a conventional impression. You don't want any blood. You don't want a lot of moisture. Dry that area off. But we're not going to beat a dead horse because we had this conversation on a previous episode. As always, thank you for joining. Thank you for listening. And we look forward to bringing you more content in the next few weeks.
All right. Take care, guys.
Have a great day.